Thank you very much, GIS, for giving me this opportunity and inviting me for this talk. Basically, I'm presenting Asia Pacific Society region, being a Vice President of Asia Pacific Society of Cardiology. So, this is a network which in Sindh province we have 11 hospitals and 30 chest pain units. Coming what Dr. Jamal from Jordan said, that how expedite or prioritize a patient with ACS or STEMI to the hospital. So we have network of 20 chest pain units in Karachi, and Karachi is about more than 20 million population city, very highly populated. And this chest pain unit is basic chest pain unit where patient can be identified, and from that one click, the cath lab in our centers, 3 of 11 are in Karachi, where they can show that patient is coming. So proudly saying that we did approximately 18,000 primary PCI last year, so probably this might be a world record. So disclosure none. So today I'm going to present one of these cases, and you know that as volume is very high, you can have any kind of patient. This is very young male presented with bilateral shoulder pain radiating to back and profuse sweating for 2 hours. He is battle nut addict, chalia, we can say in Urdu, and there is no past significant history. This patient presented to ER with this ECG, and it's clear-cut STEMI. During presentation, patient was vitally stable, blood pressure 110/70, heart rate, respiratory rate, oxygen saturation. But unfortunately, in ER, he has ventricular fibrillation. 4 minutes CPR, patient intubated in time, but he was maintaining his blood pressure. So with the diagnosis of extensive ventrival MI, patient was taken to the cath lab. This is end diastolic pressure, which was expected to be high, and this is right coronary artery. Easily you can see that's a proximal severe disease in right coronary artery, and but horrible picture is this. So patient has occluded left main. So we have started with guiding catheter, suddenly put a wire to restore some flow, and then we put a stent, 3.526 deployed it ostial LED to left main, and then part with 408 NC balloon. Fortunately, flow was good, flow was restored, but at this point of time, there is a slight hope, and that makes us a bit brave to intervene circ as well. Then we put a wire in circ and ended this procedure by kissing with acceptable result with circ. And this is a final result. It is followed by IBUS, which showed adequate expansion of the stent and good apposition. And patient was extubated within 36 hours post PCI and discharged home uneventfully. Few days later, we called this patient for a stage PCI of RCA because it was a very severe lesion, and it was done uneventfully, and we have had look left system. Then it was fine. So the take-home message is, don't let Widowmaker win, because occlusion of LED is classically said as a Widowmaker. Act fast, intervene boldly, and restore the thread of life, because timely PCI can transform nothing into beating heart. Thank you very much.
Thank you very much.